algorithm, if you go by dictionary, it is a set of rules for solving problems in definite number of steps, or in the computers, it's instructions to transform input data into processed output data, and it's derived from Greek word arithmos, that is number. So let's go in the stepwise manner: acetabulum, femur, then classification, and there is something, this will be done in short time by machine learning and artificial intelligence. So algorithm basically give us guidelines. They are useful for us. We don't have to think. They are ready. It's like a ready reckoner. They can be useful in deciding whether it's septic or aseptic loosening. We had some time back, we had metal on metal cases, and there were revisions, spate of revision cases. So you can decide when to revise, when to watch. We can classify defects. On the acetabular side and femoral side, there are bone losses, and we can decide the appropriate implants and treatment. There are revision scenarios can be in periprosthetic fractures. These algorithms give treatment protocols to us, and instability, again they give us treatment protocol. For example, a case like this, and top one, it is no brainer to know that it is loose, it's infected, and there is a discharging sinus. A case like this, it is a subtle type of thing. There is a fluffy callus there, there is a hypertrophy of the stem, but this is 19 years post total hip replacement and painful. So many times it is difficult to know. We have these guidelines of history, physical examination, ESR, CRP, joint. This patient, for example, had high chromium cobalt level, and it was a metal on metal. We did not have the stickers of this, but it did not osseointegrate. What is known as a fibrous union that it had, or initially was stable, but later on it at 19 years there was a trunionosis. There was totally this totally loss of this HA coating, and it was revised to a distally loaded prosthesis. So we have, even for the imaging, we have these algorithms in place when to do what. For aseptic loosening, what helps you. If you have metal on metal ultrasound or MRI, Mars MRI, so on and so forth. So these guidelines sort of help us. For mom or metal on metal, we have to rule out infection. We have to classify them into 3 groups: moderate, moderately high, and high risk. And if you have both the factors exist, over 7 per part of billion, or adverse reaction to metal debris, then you have to revise. But if these are one of these exist, or the implant track record is not good, then you have to take a call. So these are sort of algorithms which tell us. For infection, we have MSIS guidelines. We have major criteria and minor criteria, and we have one major criteria, or at least minor criteria, giving a points. So more than 6 is definitely infected, 2 to 5 is possible infected, and 0 to 1 is infected. So again, these are pre-operative and intraoperative diagnosis. So all these help us to know, to come some sort of conclusion. And in future, I'm sure this will not will have to be done by the surgeon, but artificial intelligence will tell us, and they will give us a ready reckoner. So this is Paprosky's famous algorithm. We have bone losses, and we have various type of classification from 3A, 3B, acute discontinuity, chronic discontinuity, and possibility of what we can use in this sort of scenario. Same thing exists on the femoral side, where you have classification and algorithm based on what stem can be used in which sort of a thing. For example, a type 1 defect, you can use a primary stem. If it's type 2, you have to use a fully porous coated stem. And type 3 and 4, you have to do distal loaded or modular stem. And type 4, you don't have purchase, so it is perhaps a total femur replacement. Sorry. Yeah, thank you. So same thing in the periprosthetic fracture. You have A, B, C. You have fixed stem. B2 is loose stem, and B2 is good bone stock but loose stem. B3 is bad bone stock and loose stem, and C is beyond the tip of the prosthesis. So we have this algorithm in place. If it is A is around trochanter, either greater trochanter or lesser trochanter. If symptomatic, you require fixation. Now what is now current thing is B2. Previously it was with the loose stem, it was suggested that we have to always revise, but it is not so. They have found that we can do open reduction and interfixation if the bone stock is good. So this is something new, and algorithm will keep on changing as per the experience goes, and the new things will come up, and the old things will be out from the algorithms. So they keep on changing. It's a busy slide. I'll go rapidly. Same thing exists for the periacetabular interop fractures of the acetabulum. So the periprosthetic fracture, that's the algorithm. If you have cemented or uncemented stem, we have to see whether the functional demand is less, there is a higher anesthesia risk, many comorbidities, only one zone fracture. So B2, all B2 fractures are not the same. In these cases, perhaps if you have intact cement bone interface, you can fix even in B2 type of fractures where the stem is loose. If it is B2 but you have high functional demand, low anesthetic risk, the cemented the bone loosening, then we have to do a revision processes. So again, the algorithms come to our rescue when it is a severe defect, almost hinging on the pelvic discontinuity. 3A defect is up and out and up and in. These are very popular sort of classification given by Paprosky, but we have seen that inter-observer and inter-observer reliability is very low. So we have this in place where we can put in augments or dome augments or flying buttress or footing augments here. And now it's going to be the era of artificial intelligence, where machine is going to, the artificial intelligence is going to predict which are the situations which are high risk for re-revisions, and they will detect the implant, they will detect perhaps that they will predict the failure, they can make decision in the post-operative period, they can have they can detect early loosening, which is not possible by our naked eye or by human eye. And we have these clinical outcome scores, and based on this, perhaps the artificial intelligence is going to, in near future, is going to tell us which hips are going to last, which hips are going to, will not last. They can predict implant size by 3D templating. It can pick up wear and osteolysis hip failure and predict failure based on outcome measures. Yeah, thank you.